I think the lines are live, so I will get started. Good afternoon, everybody, or good morning if you're on the West Coast. This is Larry Bernalia with the Healthcare Practice Group of Foley and Lardner, and with me today is my colleague Jennifer Walsh. I'm the chair of the Healthcare Practice Group here at the firm, and Jennifer is our Director of Public Affairs with considerable experience in healthcare. She's got about 20 years on the Hill in state legislature and also in private industry, where she worked for 4 years in government affairs in an extremely large healthcare company working on projects like this. The subject of our call today is a very significant change to the treatment of certain off-campus outpatient hospital departments that came about through a last-minute addition to the Bipartisan Budget Act of 2015 in Section 603. We are going to walk through what this change did and what the impact will be to you. We will have some time for questions at the end, and we will give you a flavor of some of the efforts that the industry is looking at to address some of the problems that arise as a result of this. Also, we think that CMS, the Centers for Medicare and Medicaid Services, is going to have to offer some interpretations of the law. In fact, the statute contemplates that. We don't have any of that just yet, but we'll be waiting for it. So before we get into the details of it, let me just remind folks that when we're talking about off-campus provider-based departments and the cost implications, it's a subject that has been given a number of episodes of attention over the years. MedPAC, the OIG, and others have long looked at the cost issues of off-campus departments, particularly those that once were physician offices, and thought that they were an opportunity for some cost containment. When this particular piece of legislation was introduced in Congress about 2 weeks ago, the Congressional Budget Office thought that the savings attendant would be around $9.3 billion over 10 years. So it is a cost containment exercise for sure. So I see that we've moved right on into our slides, and that's good. I'll be able to control them from now on. So here's the short, quick and dirty of what this provision of the law does. And Jennifer, you should feel free to interrupt with any commentary along the way if you like. So the short of it is that as of January 1st, 2017, an off-campus outpatient department of a provider will effectively not be able to bill under OPPS, the Medicare Outpatient Prospective Payment System. They will be prohibited if they are new. Let me tell you the categories of off-campus outpatient departments of providers that will be able to continue to bill under OPPS after 1/1/17. There's effectively two. There are grandfathered facilities, and there are dedicated emergency departments. Now remember, we're only talking about off-campus. This does not apply to on-campus departments, whether they're new or old. And I'll give you some commentary about that in a minute. So after 1/1/17, if you're not grandfathered, or if you're not a dedicated emergency department, and you're off-campus, you'll need to find another way to bill Medicare. Principally, that will be the freestanding setting fee schedules like the Medicare physician fee schedule or the ambulatory surgery center fee schedule. This is largely what the detractors have wanted to see for years, and that's what they got when the president signed this legislation on November 2nd. So let's unpack some of these concepts a little bit, and you can figure out how it might apply to some of the projects that you have under development within your organization. First, let's talk about what is this outpatient off-campus department of a provider. We're talking about provider-based departments, and so those of you who have worked in the regulatory arena for a while are familiar with the provider-based regulations at 42 CFR 413.65. These have been enshrined in regulations since around 2000. They haven't changed very much, but there has still been a lot of activity around the compliance issues for the provider-based regulations. My view is that those compliance issues just got a lot hotter. As I said in the beginning, this only applies to off-campus departments. They're the only ones who are going to be subject to this ban. It does not apply to provider-based departments which are on the main campus of the provider or within 250 yards of the main buildings. That's the traditional definition of on-campus and off-campus under the provider-based regulation. But note that the statute also speaks to on-campus being within 250 yards of a remote location of a hospital. And remote location is a term of art in Medicare rules. And what that refers to is an inpatient site that's off-campus. So we have this sort of multiple campus vision for this one particular rule within Medicare. I would also like to note that under the regulations, the regional offices also have discretion on a case-by-case basis to determine whether or not a particular facility is on campus or off campus. It's an issue that hasn't received a lot of attention because the distinctions between on and off campus haven't been all that material in the past, except with respect to organizations that are under a management contract or are joint ventures. But now you can see that they have a real big importance because they will allow a new provider-based department to continue to be billing or to bill under outpatient prospective payment system if it's on campus, and it wouldn't if it's off. So I think we're going to see a lot of questions and interest around what it means to be on campus, and very likely we will see some more guidance out of CMS on that. I can tell you that last week I was speaking to a well-informed hospital CFO who told me that he thought there would be a lot of sky bridges being built now to potentially expand the definition of what's on campus and off campus. I also note that a variety of differences are out there in the regions as the MACs, or the Medicare Administrative Contractors, or the old fiscal intermediaries, have historically looked at on-campus and off-campus in different ways and measure from different points. I'd also like to note that the off-campus department of a provider does not apply to rural health clinics or federally qualified health centers, except for certain FQHC lookalikes. And if you are operating an FQHC lookalike, that carve-out is very important to you, or if you were hoping to open one. So that's how we define this off-campus outpatient department of a provider. Let's talk about what it means to be grandfathered, because I said that this principally is designed to apply to new off-campus provider-based departments. And to get grandfathered under the statute, the department of the provider has to have been billing under the outpatient prospective payment system for covered outpatient department hospital services prior to the date of enactment. And under the language of the statute, it actually says prior to the date of enactment of this paragraph of the statute, which is kind of an awkward phraseology, and some folks have tried to read into that language a future date for grandfathering. And it very well might be that that's how it should be interpreted, although a perhaps better reading or a more natural reading of the date of enactment of this paragraph is the date that the act was signed by the President, which is November 2nd, 2015. So effectively, the safest reading of the grandfathering is if you were billing under OPPS, maybe even just one bill, prior to November 2nd, 2015, your off-campus department is grandfathered. And if you weren't, then it's not. Now, I've said that there were two ways to survive. One is through grandfathering, and one is through being a dedicated emergency department. Let me explain this a little bit as well, because this is the second exception to the ban for new facilities. Dedicated emergency department is a term that in the drafting of this legislation was borrowed from the EMTALA regulations, the Emergency Medical Treatment and Labor Act, or the Patient Anti-Dumping Statute. And this was a regulation that was created at a time when there was uncertainty in the provider community, as well as at CMS, about which off-campus provider-based sites would be responsible for the full panoply of EMTALA responsibilities, as opposed to just having to follow the conditions of participation relating to safe treatment of patients. And what CMS did was it created 3 ways that your off-campus department must comply with EMTALA because it was a DED. And those 3 are here on this slide. Either your department was licensed by the state as an emergency room or emergency department. Second, it was held out to the public as a place that provides care for emergency medical conditions on an urgent basis without requiring a previously scheduled appointment. Or, and this was a catch-all, at least 1/3 of all the outpatient visits were for the treatment of an emergency medical condition on an urgent basis without requiring a previously scheduled appointment. Now, take a step back for a minute and think about what was going on when the regulation was written. They were trying to grab more departments and have them comply with EMTALA. Well, by sweeping this in some respects, it's convenient for providers who are hoping to be able to latch onto the DED definition in order to have a new off-campus facility be able to bill under OPPS and not the freestanding one. So our view of this statute is that if you can meet any of these 3 criteria, then your department is a DED, and you may continue to bill. You may bill under OPPS, whether you form it a year or 2 years or 10 years in the future. And that's an important thing to think about. Of course, that comes along with the baggage of EMTALA, but you got to take it all if you want some of it. So those are the 2 ways that new departments can be free of the ban on OPPS billing. The statute also includes some requirements that CMS start collecting information to implement the paragraph, effectively this new law. There are probably some arguments that the healthcare bar will raise that Section 603 requires regulations to be implemented, and it remains to be seen if CMS will embrace that view or not. It's also entirely likely that in CMS's efforts, it will expand upon those facilities that may benefit from grandfathering. I suspect that is within their purview. Although probably what was intended by this provision is relating to the claims modifiers, which CMS was rolling out last year and next year for off-campus outpatient department billing, which is kind of an interesting thing because CMS introduced new claims modifiers for provider-based departments so that it could study where these facilities were and what their cost structure was, perhaps, and what the utilization would be there. Congress kind of jumped the gun by implementing this statute prior to CMS having the opportunity to analyze these data because they hadn't yet been collected. We still don't know what CMS is going to do with the authority, but it's clear that they have a broad ability to collect data. The last part of the law that I want to share with you before we provide some commentary about it in addition to what we've said so far is that the statute also prevents aggrieved providers from appealing a variety of things that they may choose to do under the provisions of Section 603. So they cannot appeal the services that are excluded from OPPS as a result of the statute. They can't appeal what other billing systems might be eligible for billing. We can't appeal whether any specific off-campus department is subject to the ban. I find that very odd because right now there are appeal rights for denials. It's also possible that the providers are unable to appeal a decision that they are not grandfathered, as well as all that information that CMS, according to the last slide I showed you, is able to collect. So it's a relatively short statute. I've just walked you through the principal components of it. Let me offer a few comments before we pause for any questions you might have and some additional commentary from Jennifer. So these are some of the things that I wanted to make sure that aren't lost as you read this. The first thing I want to say is that regardless of whether your department is grandfathered, a DED, or whatever, it can start and keep billing as provider-based throughout all of next year. So even if you built a new provider-based off-campus department tomorrow, which presumably isn't grandfathered, it would be allowed to continue billing under OPPS through 1/1/17, but at that point it would need to find another category to bill under as a freestanding organization of some sort. I want to say a second thing, which is that it's important to be careful that you know and start thinking about those other payment categories. Some of those payment categories, as people are starting to look at it, might actually be beneficial from a reimbursement perspective. Others are most certainly lower in reimbursement than the current OPPS rules and payment systems permit. But there are probably a category of services that are presently able to be billed in a hospital outpatient department under OPPS for which there might not be another relevant freestanding payment category. And partial hospital might be one of them, and there are probably some others that people will think about along the way. A third thing I wanted to comment on is that this statute only affects the payment rate for the services that are being rendered to Medicare patients. It does not say that the non-grandfathered departments aren't really provider-based to the hospital, nor does it say they're not outpatient departments of a hospital, for all what that means. And so I think that all the outpatient hospital rules will continue to apply, as well as the additional benefits that might be present and available to beneficiaries who seek services at a hospital outpatient department, which might include access to 340B discounted drugs, as well as some of the limitations that apply in departments, such as the 3-day DRG payment window, which would apply to a freestanding setting anyway, and all the regulations that tell hospitals what they have to do when they have a hospital outpatient department that's provider-based to the main provider. I think I noted before, but I'll say it again, that if you're going to latch on to the DED definition, and then there are probably a lot of freestanding departments or off-campus departments that could, ortho and other settings where people are going to show up in an emergent situation, just be prepared that you're going to have to comply with EMTALA at those departments. Many providers had voluntarily agreed to accept EMTALA responsibilities at those departments, even if they didn't technically qualify as a DED. And CMS had long said that even if you don't need to comply with EMTALA, the conditions of participation bring along with them many protections for patients. So this might be a distinction without much of a difference, I guess, unless you have an EMTALA violation. I think that with respect to the DEDs, though, we are probably going to need to find a little guidance from CMS to clarify that all services within that department are billable under OPPS and not just those emergency services. I think that's the better reading of the statute, but I'm going to suggest that folks do stay tuned for that and a lot of other important interpretations that CMS might offer. This is a pretty fast-moving process. The law was passed very quickly. The provider community and its representatives were given the opportunity to weigh in, and there were some valuable changes that were made to this statute as it made its way around the Hill. And but still, I think a lot of providers woke up Monday morning scratching their head and reading about this when it came across the blogs from their advisors or their trade associations. And so there are some efforts to modify the law. I'm going to turn to my colleague Jen and ask you, Jen, to offer any commentary you might wish to with respect to those efforts, I can tell you that we are involved with some as well, and maybe Jennifer can offer some thoughts on that.
Sure. Thank you, Larry, and hello, everybody. So picking up on what Larry said there's definitely some acknowledgement within Congress that there were unintended consequences caused by this language, and that because it was written quickly, perhaps it wasn't written as artfully as it should have been. That said, there are efforts afoot to try to make some technical corrections to it in the next couple of weeks before Congress adjourns from the year. That said, that will require significant efforts and some very heavy lifting because, as many of you are probably aware, there are not a whole lot of moving vehicles in the last couple of weeks of the congressional year, and there are other priority issues that have to be accomplished. So there are efforts underfoot. Foley Public Affairs is interested in working with you to make sure that you benefit from whatever ends up in any sort of year-end package. And then beyond that, into next year, there will probably be ongoing legislative efforts, and clearly, as Larry described, there are going to be a lot of regulatory and implementation issues. So that's sort of a high-level overview. Again, we would love to have the opportunity to work with you if anybody's interested in discussing that further regarding what Congress is considering right now and what we think is most likely to happen. Our contact information is at the beginning of the slides.
And we urge you to send an email to us right away, like during this program. So thank you, Jennifer. And, Jen, feel free to chime in during our question and answer session if you like to. But at this point, we've walked through the things we hoped we would be able to tell you about what the statute says. There are a number of unanswered questions, as is often the case, but we can try to answer a few of them for you now. I see that a number did come in through our chat feature. I've got 13 of them here, which is great. But Sally or Brian, do you want to open the line and see if there are any live questions that we should field first?
Certainly. Ladies and gentlemen, if you would like to ask a question, please press star 1 on your telephone keypad. We'll pause for just a moment to compile the Q&A roster. Again, if you'd like to ask a question, please press star 1 on your telephone keypad.
And if we don't have any, I'm happy to just go right to the Q&A online.
There are no questions at this time.
All right. Well, why don't I just start running down our list until we run out of good questions or run out of time? What do you say, Jen?
Sounds good.
The first question we got is, does an outpatient department of a provider that's off campus and wants to rely on the urgent care standard need to be open 24/7? I think that's going to be highly dependent on state law. States like Massachusetts, which license off-campus emergency departments, do look for that. I'm not sure that every state does, though. Next question. Can you provide some insight into how HRSA will interpret the law in applying 340B? That's a great question. Our reading of both the 340B requirements and this new law, Section 603, would inform us that the change in the statute for 603 should not limit your ability to continue to take advantage of the 340B program, because to be a 340B provider, you don't have to be billing under OPPS. That's not what the HRSA rules say. It says you have to be on the cost report for a year as a hospital outpatient provider-based department. So our view is, unless HRSA chooses to mess around with its guidance as a result of this, and we haven't heard anything that they will, your 340B should be okay. We got another question, which I think is a really key one, so I'm going to ask the question and then refuse to answer it. It says, currently we have a hospital outpatient department that would qualify for grandfathering under the current statute. If we decide to change the location of the outpatient department, resulting in a new address, would the HOPD still be grandfathered under the new location? And that's one of the issues that some of the legislation is designed to address, some of the correcting legislation. Jennifer, did you want to speak to that?
Yeah, I think that, as Larry said, there's definitely a desire to explore further possibilities of broadening the grandfathering in the existing statute, and likely giving the Secretary some additional discretion in expanding the grandfathering. And I think the type of facility described in the question is exactly the type of thing that they're trying to get after.
I think that between now and until some clarification that's official is published, a department would be at risk to make a change such as you described without getting some clear guidance from at least the regional office and probably the central office to do so. Next question. It says, where are we? The question was, do you believe that this section will have a chilling effect on physician practice acquisition activity, especially when such acquisitions are part of a strategy to expand 340B billing? Well, that's a good dual question. As I said in response to a prior question, our view is that 340B drug pricing should not be molested as a result of this change in the law. So if the strategy is relating to the ability to access 340B drugs for the benefit of the population, that strategy should still be viable. Certainly, there is now a powerful disincentive for expanding hospital services in off-campus locations, because all of these off-campus departments are going to be subject to the same cost structure, overhead, and regulatory burdens that they were before. They still have to comply with the Joint Commission standards. They still have to comply with the conditions of participation and the provider-based regulations and all of the costs that go along with it, but they just don't get paid for it anymore. It was a very blunt instrument. So in that respect, the financial feasibility of many of these projects are in fact called into question, and I suspect that in response to your question, they will be chilled. Next question. A lot of the questions are similar, which is why I'm taking a little time to make sure that I don't try to answer the same question twice. A lot of questions about 340B, which is, I think, a perfectly reasonable place for people to be going. A number of questions that are coming in now about provider-based departments that move. I'm not sure if one of the questions has been asked yet, but I'm going to predict one. In addition to departments that move, one of the questions that we've received and thought about ourselves relates to departments that materially change their services along after the date that the grandfathering ended. So take, for example, a grandfathered provider-based department that was in existence for the last 10 years and then has a significant change of services at that site. Certainly, the provider would argue that the department remained, and there's good authority for that in the provider-based rules. There's a regulation that speaks to material change of a provider-based department and the ability or requirement to notify CMS upon a material change. And that regulation doesn't say that a whole new provider-based department is created, nor does it say that a new attestation is required. Yet, it's a good question, and probably one that in this sort of new period where there's a lot of gray areas, big changes to the departments may require some additional guidance from CMS before you can be fully confident that you don't have a problem from it. One of the questions is, under current rules, a provider-based department can be within 30 miles of the main campus. Does this section 603 eliminate that provision? And the answer is no. The existing regulations allow the 35-mile rule to apply to off-campus provider-based departments. Nothing in the statute eliminates that provision. My read of the statute is that all of the provider-based requirements continue to apply to the non-grandfathered, non-DED sites. You just don't get paid for it anymore. Next question is, do you anticipate that patients will continue with 2 copays, 2 deductibles under the new payment methodology? So the question is this split billing now? I'm not sure this is split billing anymore. I think that a lot of these are going to be freestanding sites that may be just receiving a single bill. So from a certain perspective, this may be convenient for your community and would result in patients no longer getting a split bill. Although I think that Congress left the door open for what freestanding sites are going to be able to bill under. So, for example, if you were billing under an ASC fee schedule, you would still see a physician's fee there as well as an ASC fee. I think that's part of the job that you're going to have to undertake when you're evaluating the business model of your project. That is a non-grandfathered project. There's a question on here, Jennifer, that I think is an interesting one that I might see if you're comfortable answering. It says, this provision is part of a 2-year balanced budget deal. What happens after the 2 years? Do you have any thoughts on that, Jen?
Well, the policy, as I understand it, is intended to be permanent. So the fact that it's a 2-year budget bill, that doesn't mean that this provision would go away in 2 years.
Yeah, that makes sense to me.
The 2-year budget bill just really means that Congress laid out its vision for spending for the next 2 years.
Okay. Next question we've got here says, would you please provide your thoughts about remote locations and how the existence of a remote location may impact HOPDs in the future? This is a very good question because it keys into one of the points that we made on an earlier slide, that under the statute, a department would not be subject to the ban of being an off-campus outpatient department of a provider if it's within 250 yards of the main campus or a remote location of the hospital. So I think that means 2 things for us. The first thing it means is if you have a remote location, then you have another little orbit of a 500-yard diameter around that facility on which you could build a new provider-based department which would be able to bill under OPPS. The other thing it means is that providers will need to start thinking creatively about whether it's worth the expense and is there a value in creating a new off-campus remote location with inpatient capacity as part of a project that would include both inpatient and outpatient services, the outpatient services for which would be eligible for OPPS reimbursement. I think that is a new planning question thanks to the definition. We got a good question about the physician supervision rules, and I think this is one that probably a little guidance will be helpful in, but I have a hunch about where the outcome will be. It says, which definition of direct physician supervision should be followed in a non-grandfathered off-campus department, hospital department, or physician office? I think that that is a good question because if for a payment rule, I think Congress is hoping that the hospitals will then comply with all the payment rules applicable to the freestanding setting. If, on the other hand, you're looking at a condition of participation, I think they will continue to apply the old hospital rules. And while the jury might be out, my hunch is that the physician supervision rules would be viewed as a payment rule. Next question. If you have been billing as an HOPD, a provider-based department, but have not submitted an attestation, should you proceed with submitting an attestation, or would that not be necessary under the new statute since you have been billing as such? This is an interesting question. The rules on attestation have never changed. It is not mandatory that you bill that you submit an attestation to declare provider-based status. You may, if you conclude that you comply with the rules, start billing as it. The risk now of submitting an attestation, I think, has increased because if you submit an attestation that you are provider-based and CMS declines it, I suppose there's an argument that when you finally comply with the rules and start billing under OPPS there, that you might be a new outpatient department of a provider. I can see that argument being made. I would reject the argument and defend against it by saying that the statute does not say that you have to have been in full compliance with the provider-based regulations. Rather, it says, were you billing under OPPS? And you were. Maybe you had a problem with the provider-based regulation compliance, but that would be my defense should someone choose to raise that question. Next question. We have planned 2 expansions of existing off-site provider-based departments. These have been planned for a long time. Will these be considered new departments and have to bill under the Medicare physician fee schedule, or could we still bill under the HOPD since they are expansions? This goes back to a point that I was raising before, which is that I think CMS is going to have to recognize that changes, modifications, or expansions to the departments are going to need some additional guidance. Certainly our argument would be that the department was there, certainly at that location, and it had been billing under OPPS prior to November 2, 2015. So we would certainly argue that it is not a new department. It is the same old department, but services have changed there. Again, that's one of those areas where I think CMS is going to need to provide some clarity to comfort the provider community, and you can see why they would want to do so. Otherwise, we would have an ongoing compliance nightmare around this issue. Next question. Currently, professional services provided at a hospital outpatient department setting are subject to the site of service reimbursement differential. Under BEBA, with site of service neutrality and reduction in professional reimbursement, the reduction in professional reimbursement should be discontinued as a policy. Your thoughts? I agree with the question. I'm not sure that that Medicare will, however, and that's probably one that would need to be raised up with the agency. But you're probably right about that in terms of the site of service differential. Now I note that you still have a facility which is not owned or an expense of the physician as a result of this change, which has a variety of other sort of consequences along the way. Going back to the question about whether or not it's a split bill, in facilities that aren't split billed, CMS also takes the position that when physicians bill there, that could be remuneration to the physician under the Stark Law. That's a provision that came out under the Medicare physician fee schedule just about the same time this law was passed. And it's one that I think that the provider community is going to have to stare at as you're thinking about some of these freestanding settings where there might not be a hospital TC or facility fee being billed. It's an important one to keep an eye on. Next question. A lot of questions about adding square footage to an existing site. Does it jeopardize your grandfathered status? Again, we'd argue no, but additional guidance is going to be required for that. Will a new modality be added to a grandfathered site be reimbursed under HOPD? Same answers. I think that the providers ought to be standing firm that the department remains. It is not a new department, and there's nothing to say that different services provided at a department are somehow not the department and therefore a new department. Let's see. Got a lot of good questions here. This is are there any other live questions I should ask Sally? Are there any live questions?
Again, if you would like to ask a question, please press star 1 on your telephone keypad.
And we've received a number of questions from our clients along the way by email, and we're happy to continue to help try to field them for you if you like. As I flip through the questions, I think that many of them are principles, are variations on the theme. Here's another great one. If a site has an approved certificate of need prior to 11/2/15, but billing does not take place until after 11/2/15, do you think there'll be a strong argument for grandfathered status? I think that what you're raising there in that question is the question of what happens to the underdevelopment off-campus department. And in our view, there's a very strong equitable argument that that Congress should not impair those facilities that are significantly under development, where there's been a lot of expense incurred and government approvals along the way, perhaps. And I suspect that the area of addressing the concerns of the underdevelopment projects will probably be top of the list of some of the efforts to modify the law. In fact, some of the bills that we've seen have been working on that. Jennifer, did you want to comment on that piece?
I'm sorry, on specifically
on the do you want to comment on legislative efforts to assist with an underdevelopment department?
Yeah,
or do you want to handle that on a case-by-case basis from clients?
No, I mean, I think generally I can say that is definitely one of the scenarios that's being contemplated in any kind of a possible fix, or at least giving the secretary, kind of putting more weight on that consideration for the secretary to have discretion over the grandfathering provision. And I should also add that my colleagues and I at Foley have had extensive conversations with House and Senate leadership about these challenges regarding the grandfathering and facilities that, already had a lot of these efforts underway. So I think that, it's going to require some very heavy lifting, but that is absolutely one of the areas that's on the table.
Thank you. Here's another great question. The new regs only affect Medicare patients. How will non-Medicare and commercial patients be impacted? You're right, they only affect Medicare patients, and to the extent that there's a commercial payer contract that links to your Medicare status, I would note that your Medicare status doesn't necessarily have to change. You're still a hospital outpatient department, and if your payer contract permits you to be continuing to bill hospital outpatient fees under whatever rate you've negotiated with your commercial payer, I would suggest that that's not impaired by the law. The same should be true about Medicaid, although in many states Medicaid has made efforts for site neutrality as well along the way, and I suspect that this legislation will embolden those efforts going forward. Next question. For new sites, would there be any benefit in going through the voluntary attestation process? Answer is not much. If you know you're not going to take advantage of one of the grandfathering provisions or the dedicated emergency department provision, or you don't need to rely on 340B, there isn't a lot of benefit to going through the attestation process. In fact, there may be lots of reasons not to be a hospital outpatient department at all, and just treat it as a freestanding clinic or other enterprise like that. Next question, similar question for hospitals that have not historically completed the voluntary provider-based attestation. Is there a new sense of urgency to do so, and how quickly should we act? That's a tough question to answer because we don't know what the efforts on modification will look like, and I guess it would be an interesting problem if you had one that was close and you could have attested but didn't, and then the attestation turned out to be a element of modification. I don't think it's going to be, but I can't be sure, obviously. But going back to the answer we gave to an earlier question, it's not the attestation that matters. It's the having billed under OPPS prior to November 2, 2015 that matters. I'm jumping around a little bit on the questions. Jennifer, did any of these, are you flipping through too to see if there's any that you'd like to field?
Yeah, I've been looking through them.
I think a lot of them are variations on the important themes of facilities that are under development, facilities that move, facilities that expand, and what other trappings of compliance with outpatient hospital rules and billing requirements will apply in a non-grandfathered site. All of these are issues that I believe CMS will need to address. At this point, I've now flipped through the 39 questions we've got online and tried to answer them all as best I could. I was moving quick to avoid the dead silence on this webinar, so I'm going to stop here. But if I didn't get to your question, it may not be because I didn't want to answer it. It was probably because I overlooked it. So please feel free to call me or Jennifer afterwards or send us an email. I think our contact information may be on our slides. And
yes, it's on. It is. It's on the second page of the slides, Larry.
Do feel free to reach out to either of us, and in particular, if you're interested in participating in the government affairs initiative around modifying the statute, I'd urge you to email either Jennifer or me as soon as you can, because what's going to be really important here, and Jennifer, please add some color if you like, is making sure that the specific stories and unintended consequences of the statute are heard by folks in Congress. We know that members of Congress and the Senate, some of whom are piping mad about the impact of this on their constituents and the hospitals in their communities, are asking questions and they want these stories. So the more of these stories we have, the easier your job will be. Don't you think, Jennifer?
That's absolutely true. And I think one of the biggest challenges, I mean, time is working against us right now. As I mentioned earlier, we have a very limited window here in which to affect policy before the end of the year. And second, I think a lot of the horror stories that lawmakers have heard thus far have largely been anecdotal, but really getting in front of them with the potential impact on jobs or revenues or, you know, other specific impacts to facilities in their congressional districts and in their state is what they will really find compelling and what will really empower them to push hard to get some of these technical changes through. And without a very strong effort on those fronts, it's going to be difficult to get something else done this year.
At this point, I'm going to check and see if there's any live questions, and if they're not, I think we'll sign off. And field any other questions you might have offline or at another time. Sally, we have quiet phone lines?
Yes, there are no questions from the phones at this time.
All right. Well, with that, I want to thank you all for sharing your morning or afternoon with us. This is a moving target. We're doing our best to keep our friends and clients informed. I hope you're subscribed to Healthcare Law Today, our blog, because we're keeping this issue as current as we can through the blog postings. Again, thank you for your time today. Jennifer, thanks for being part of the conversation, and we look forward to hearing from many of you with respect to the government affairs effort. That's all I have. Jennifer?
Thank you, everyone. Nope, just thank you, everyone. We hope to hear from you soon.
Okay. Goodbye.